Okay, acute coronary syndrome represents a couple of different things: unstable angina, non-ST elevated MI, and ST elevated MI, or STEMI and STEMI. A lot of ER visits are associated with chest pain, so making sure that you're identifying whether your chest pain presentation does fall into one of these three categories is important. Is it just heartburn, or is it something more serious? MI is a big killer every year, and so it's something that if we can address it quickly, it's something we can intervene on and actually have pretty good outcomes with. But time is really important with this. So you're kind of your different tiers here. You have ST elevation in your EKG is going to show you a STEMI, and that's what that is specifically. If your ST is depressed or you have T-way inversions, then you're going to look at troponin levels. If your troponin's elevated, that's an N-STEMI. If your troponin's normal and you're still having chest pain with ST depression or T-wave inversion, that's unstable angina. So those are the three tiers here. STEMI being the most severe, N-STEMI, and then unstable angina being the least severe. This is usually due to plaque buildup in the arteries. So you get plaque buildup, a clot, and total occlusion of an artery, which causes the infarction. Unstable angina is similar to typical chest pain, but it's just more severe. And most people who have angina or episodes of angina will get it if they exert themselves. This can occur at rest, and it may get worse suddenly, come and go quickly, and that can be a a sign that things are getting progressing more severely. ST depression, T-way inversion, no positive biomarkers, which means there's no cardiac necrosis, but it's just some sort of unstable blood flow going on, or a narrowing of an artery somewhere, usually a partial occlusion. So there's usually some sort of intervention we can do, and if unstable angina is handled early, it can help help prevent a major heart attack later down the road. NSTEMIs, looking at similar chest pain, but may include some more atypical symptoms, and by those meaning they would be typical for this type of presentation, but not chest related. So arm pain, lower jaw pain, back pain, shortness of breath, diaphoresis, dyspnea, and extreme fatigue are all kind of signs and symptoms of a heart attack potentially. EKG would look similar to UA, but you would have that troponin elevation, which would indicate some sort of myocardial injury, which is usually going to be associated with a heavily occluded coronary artery. And then your STEMI would be probably the worsening symptoms. People describe it as severe pressure on their chest, like an elephant sitting on their chest, usually quite excruciating and radiating pain to other areas of the body. ST elevation would be seen on your EKG. Elevated troponin would be seen. This is a sign of total occlusion of the artery, usually in myocardial necrosis. Our goals of therapy: with UA and STEMI, we want to prevent that already partially occluded artery from becoming totally occluded, and we want to control symptoms and help the patient become comfortable, which you'd also want to do with a STEMI, but here we want to reopen that artery. And this is where things are really severe. If we let that go for too long, you're going to get significant necrosis of cardiac muscle tissue, and ultimately that can either lead to death or it can lead to later more severe complications later down the road. So initial therapy for any acute coronary syndrome is the acronym MONA, or mnemonic MONA. And it's not necessarily we'd give these things in this order, but these are the things you would give. So normally, if you have somebody with chest pain, they're probably going to call an ambulance. The ambulance is going to give them oxygen, they're going to give them aspirin, and they're going to give them nitroglycerin. They probably aren't going to give morphine at this point. They might give, I don't think many EMS actually carry morphine. They might carry fentanyl or another opioid. But generally, unless somebody's in a ton of pain, probably going to hold off on the opioids and try and manage them with oxygen, aspirin, and nitroglycerin. Usually they have sublingual nitroglycerin tablets. These are going to help open up. It's just like IV nitroglycerin, like we talked about with heart failure. It's going to open up the coronary vasculature, causes some improvement in pain relief, but there's no mortality benefits. Ultimately, you need to get them into the hospital and get them evaluated quickly. And if needed, get them to the cath lab. That's going to be the intervention here. Pharmacologically, we're only doing so much. Morphine would be a reasonable alternative if nitroglycerin's not relieving their pain. I don't see morphine used all that much, but it certainly is an option. It's effective for this, and sometimes pain can be quite severe, so you might need to use it. All right, and then we're going to reperfuse that blocked artery. So before we can go to PCI, or percutaneous coronary intervention, aka the cath lab, we're going to do a couple of things. So first of all is our antiplatelet therapy. Aspirin is going to be given. These patients might be on aspirin. If they already took an aspirin, make sure they've gotten at least a full strength aspirin dose. So a lot of times we might just top them off. So if they're on a baby aspirin and they took it that morning, we're going to give them another 3 tablets to make up the full, basically 325 milligram dose. If they haven't had it at all, they're going to chew a full strength aspirin quickly. If they're non-responsive for some reason, you can give aspirin rectally as well, but they should get an aspirin in. This is a typo, sorry. P2Y12 inhibitors, not PG. P2Y12 inhibitors are indicated for this, and we talked about those in the acute phase. At our hospital, we always use ticagrelor, but all of them are technically indicated. The glycoprotein 2B3A, sorry, I'm just bad today, inhibitors could be used too, and those are more used for acute situations in the cath lab. Antithrombotic therapy. A lot of these patients are going to get heparin, and some might get bivalirudin too. Fondaparinux and low molecular weight heparin have some indications too, which we'll talk about. And then our ultimate goal is cath lab intervention. That's gold standard. If they can't get to a cath lab in a reasonable amount of time, we give them a clot-busting drug, aka a thrombolytic. And we'll talk about all this in more detail here. Okay, so cath lab, you guys probably know what this is. You put a stent in, opens up the artery. So going back to UA and NSTEMI, you have a couple different risk stratifications that we'll talk about very briefly here. So there's this thing called a Timmy risk score, and it depends on these criteria listed here. And it just depends on a couple of things. So risk stratification is necessary for determining invasive or conservative strategy, and whether thrombolysis is indicated for this specific episode. So the different scores, depending on how many of these things you get, equal different percentages of mortality. So, the higher the points, the higher percentage of mortality you're going to have. So with unstable angina and STEMI, you're looking at 2 different methods. You can do an early invasive strategy. So if somebody's got a high Timmy risk score, you might want to try PCI as soon as possible. So within 12 hours from hospitalization. Delayed would be 12 hours, greater than 12 hours after hospitalization. Conservative would be maybe somebody who's no risk and you don't end up going to the cath lab at all. Thrombolytics in UA and NSTEMI have been studied in a variety of patient populations. They've actually shown that there's no role for them, and they actually increase bleeding risk overall. So we don't give clot-busting drugs to these patients. You have to, if you're going to manage them and reperfuse them, you do cath lab and you manage that appropriately. So you'd either have to transfer them, and a lot of times you have plenty of time to get them to a hospital that can do cath lab if your hospital can't do that. Okay, so things to consider invasive strategy, and I'm not going to go through all this, but these are information here. Conservative strategy, really just a low TIMI risk, or maybe a high risk of procedural related complications. STEMIs are much more severe. There's no need to risk stratify. You need to get them to the cath lab as soon as possible. Nationwide benchmarks are door to balloon within 90 minutes. So it's really important that once they get identified as a STEMI patient, you get them their medications instantly. I've been in the room for, I don't know, hundreds and hundreds of STEMIs throughout my career, and it's very fast. They come in, they get their meds, they're out, they're in the cath lab as soon as possible. I work at a big cardiovascular center, so we have a number of cath labs ready to go at any given time, but it is really, really quick. And that's ideal. Door to balloon within 90 minutes. I think our hospital has got it down to less than 60, and a lot of patients less than 30 minutes. And there's a lot of times where they're probably getting, they're in our emergency department, or they're going straight to cath lab from the ambulance and they're getting ready right away. So it's really quick. for a good center that's doing this quite a bit. If you can't get a patient to the cath lab within 120 minutes, you're going to give pharmacologic intervention, ideally within 30 minutes. So you would know, based on your critical access hospital, if somebody came in with a STEMI, like we can't get you, even if we helicopter you to the nearest, like if you're in the middle of nowhere, in the middle of like northwestern Minnesota or something, we can't get you to Duluth or wherever there might be another center, who knows, I don't know, Fargo, or use your imagination to figure out where you might need to be, but you could be pretty remote and be maybe in a situation where you're outside of that. Now, a lot of places like Abbott, for example, have actually built some centers in different parts of Minnesota where we can have people brought to for catheterization procedures, and designed to kind of look at where are our dead zones. So if we're within, where could we not fly somebody with 120 minutes to get them to a cath lab in time? So there's some strategies that certain health institutions will take and look at that way and say, where could we position ourselves where we can catch some of these patients? Because ideally, PCI is the gold standard, and we get them to a cath lab. Thrombolysis is really only if you have to do it. Rescue PCI, so if you give somebody a thrombolytic drug, and we're talking about alteplase, TPA, I had a slide on it on the anticoagulation lecture briefly, but if you fail that, then you're looking at rescue PCI, and this would be a sign of somebody going to instant heart failure, unstable, or going into cardiogenic shock. Okay, so this looks confusing, but it really isn't that bad. And I put these slides on here just to show you the differences between our strategies for antiplatelet and anticoagulation management. Basically, in a STEMI, so you got STEMI and UAN STEMI. STEMI is pretty straightforward. You're going to use UFH, stands for unfractionated heparin, so just regular heparin. If you give somebody heparin or bivalirudin, or plus you're going to use your antiplatelets, which is your aspirin plus one of your other drugs here. So again, at Abbott, we use aspirin, ticagrelor, and usually heparin. That's pretty much it. So STEMI is pretty straightforward. UA and STEMI gets a little tricky, but the thing to remember about this is you have time on your side. So you don't have to, heparin works quickly. We don't care about really working quickly because it's probably going to be a couple hours before they get to the cath lab. So normally, you could give them even like enoxaparin. You can give them regular heparin too. Fondaparinux, another injectable sub-Q one, or sub-Q direct thrombin inhibitor you could use. And then aspirin plus things. So it's really the same thing. You could use the exact same strategy for both. And in most cases we do. We use heparin generally for these patients. We're going to give them their aspirin. And then we're usually loading them with clopidogrel. Instead, clopidogrel is cheaper. It takes a longer time to work, but at this point we don't care about that. So we're going to save a few bucks on the ticagrelor treatment and give them clopidogrel. For initial conservative strategy, normally you're just anticoagulating them and then doing a similar thing here too. So it's not really any different between the two. You can see bivalirudin isn't on here, which you wouldn't generally use bival for a N-STEMI anyway. You'd probably just use heparin. So for the most part, you can weed a lot of this out. We really are using subcutaneous medications. We're using unfractionated heparin. These patients are going to be in the hospital. We're rarely going to say, okay, take your Lovenox and go home and come back to the cath lab. It's probably not going to happen. It's probably going to say, okay, we're going to admit you as observation, or we're going to admit you overnight and then we'll get you into the cath lab tomorrow morning when we can schedule you in there. That's usually more the strategy for an N-STEMI. For a STEMI, they're going to get to the cath lab right now. The P2Y12 medications are all here. You can see that we've talked about these already, but just a reminder that our onset of action is most rapid with ticagrelor, and it's not a prodrug, so there's no, you don't have to consider any genetic polymorphism issues when you're loading somebody with ticagrelor, so you're going to get a more consistent response in a broader ethnic group population. This slide is showing you aspirin's role versus the P2Y12 roles and where they kind of fit into play. We just talked about this. I don't think there's anything new on this slide, and this is really more for your information only if you want to look at it. But it does go through some of the post-PCI stuff, so if you're curious, what do you do afterwards? Well, usually, we already talked about this too, but usually people post-PCI are going to get aspirin indefinitely. They're going to get clopidogrel or prasugrel, or they could get ticagrelor. So really you're looking at these continuation medications, but that's pretty much the scheme of things. We've already talked about this. This just shows you all the doses and things like that if you're curious and wanna keep that, you know, slide for a reference at some point in your career if you go into cardiology. And remember, I'm not going to ask you any questions about these, but usually these are used during PCI. They're drugs that work quite quickly and could be used in place of an oral P2Y12 if you don't have enough time to get that, or if you have some issues. Sometimes they're used in combination, but there's questionable benefit if you need to do that. It's going to be a lot of institution and case specific or provider specific reasons why they use this. One of the things that I didn't mention that's a very new drug that just came out is there is actually an IV P2Y12 inhibitor. So back to this slide. It's called Cangrelor, and it's the first IV drug. And so the idea is that it does replace these oral ones in really fast situations. So maybe you have a person coming in, you know they're a STEMI. Maybe they're coming from far away, so maybe they had a 30-minute helicopter ride. You're already looking at your door-to-needle time is already getting diminished, and you want to get them reperfused fast. You don't have time to give them an oral medication and wait for it to work, so you give them IV. And so we've been seeing Cangrelor used occasionally for that reason, just when you really need that extra time window to get that inhibition on quickly. It's very expensive, so we try and limit it to certain cases only, but it is a new option. I won't test you on that or anything, it's just FYI. It's a very new drug. Okay, so why exactly are we wasting all this resources and time making sure they're anticoagulated if we're just going to the cath lab? I mean, what's the point here? Well, we want to prevent a new clot from growing, and we want to prevent new clots from forming. It's possible that if you reperfuse somebody in some area, they might have another occlusion in another area. So what we don't want is to reperfuse one area and then have to go in and, I mean, somebody might need multiple stents for sure in one situation, but again, we want to make sure we're doing our best effort to prevent any new clots from coming. And remember, these don't break down any clots, but they're just going to prevent, you know, clots from growing and forming. Our thrombolytic drugs, there's 3 of them on the market. Pretty much everyone just uses alteplase, so I won't worry too much about the rest of them. But it's got and it works in about 30 minutes, so it's a fast-acting drug. The rest of these take quite a while to work. After you give somebody alteplase, you're usually going to anticoagulate them for another 48 hours plus the duration of hospitalization. That's just due to making sure that clot doesn't come back again. And then if they aren't stable, we talked about how they're going to need to go to the cath lab. They're going to need to be transferred to a hospital that can do catheterization procedure. You can see some contraindications there. Thrombolytics have a lot of contraindications that we're going to go through in much more detail during stroke. Basically, blood pressure, history of surgery, recent bleeding, active anticoagulation would be all your contraindications for those patients. Okay, so that's the acute phase. Moving into other early hospital therapy, these patients are going to be on ACE inhibitors for sure, so this is going to be started within 24 hours of an MI. It's got really good mortality benefits in anyone post-ACS, and of course we use it in heart failure too. So somebody transitions from a MI patient and then they have enough necrosis where they kind of turn into a heart failure patient right away. These drugs would still be indicated. ARB if the ACE isn't tolerated, just like our heart failure patients. We talked about contraindications, all that stuff already. If a patient's not on a statin already, they should start a statin. And actually the recommendation is that they start a high potency, high dose statin in these situations. That's a new CHEST guideline. So high potency, high dose. So this would be like rosuvastatin, probably 20 to 40 milligrams, or atorvastatin, 40 to 80 milligrams, which again is a bit of a change of pace. We used to start these people on a low dose statin and work our way up, and now it's just like, nope, just give them the high dose right away, and don't mess with any of the other types of statins because these 2 are the most potent, and those have the best evidence post ACS. Okay. Calcium channel blockers, if somebody has ongoing ischemia or angina, the non-dihydropyridines can actually work pretty decently. If they have a contraindication to a beta blocker, that's possibly a reason why, or you're using beta blocker and nitrates already. We'll talk about nitrates in a little bit at the end of the lecture, so just hold off on those for a second if you're wondering what I'm talking about there. And beta blockers are coming up too. I kind of skipped over them because usually you don't start them right away post ACS, you wait a little bit. However, if somebody immediately post ACS has some ongoing ischemia, that's when a calcium channel blocker can actually be advantageous in that time. Generally, these people aren't going to be on them long term though, and it's a symptomatic relief type thing. Beta blocker is going to be the more long-term therapy. So in the short term, yes, you could try a calcium channel blocker. Aldosterone antagonist, so this would be like spironolactone. Basically, if they're having heart failure-like symptoms, you'd try it. So keep that in your wheelhouse for heart failure. Of course, it would apply post-ACS, but only if their ejection fractions drop substantially. Beta blocker indicated as well, usually 2 to 3 days after the event. It's going to be continued indefinitely. So hopefully you're getting some similarities here between our heart failure patients and our ACS. Beta blockers and ACE inhibitors are both indicated for both, and both required therapy for both. Statins should be targeted aggressively, and again, we aren't targeting LDL aggressively. That's old. Dose should just be dosed aggressively. Dose aggressively. Remember, statins alone are kind of the gold standard here. We don't really care what the LDL is. We don't care if somebody's LDL is great. We want to give them a statin and a high-dose statin. It's shown to improve long-term mortality benefits, regardless of what their cholesterol is. So ACE inhibitor, beta blocker, and statin, and then your long-term antiplatelet agents. I don't think I have those on here, but we talked about those already. That's back on. We can go back to this slide quick. So that would be this post-PCI, this middle slide, or this middle chunk here. Aspirin 81 milligrams indefinitely, and then our clopidogrel or prasugrel or ticagrelor, depending on the polymorphisms the patient has and whatnot, whichever one's going to work best for them. Usually Plavix or clopidogrel for most patients. Other goals, if somebody has comorbid diabetes, you want to control that with hemoglobin A1C as a diabetic lab marker, so we want to keep that less than 7. Smoking cessation, body mass index, exercise, so all kind of standard stuff there. So switching gears a little bit, if you have somebody who has ischemic heart disease but they're stable, our goal is to prevent episodes of angina from occurring. We can do this with beta blockers, non-dihydropyridine calcium channel blockers, so like diltiazem and verapamil, and our nitrates. So we haven't talked a lot about nitrates yet. Nitrates are another drug that anyone post-ACS is going to get. So all these patients are going to get sublingual tablets to take home with them. And that's in the event of them having an episode of chest pain. They can take this immediately. It helps relieve the chest pain. It also helps open up some of the arteries and increase blood flow. It helps with some of the hemodynamic management that way. It's a bridge to when they can get to the hospital, really. Not going to be a long-term solution. The tablets do degrade over time, so it's recommended that people don't hang on to these for like 6 years at a time. They should probably get a new one every year if they aren't opening it and throwing away the old one, and especially if they've opened it 6 months after opening. The tablets do degrade, and they actually have a taste to them, and I think they're designed to. I can't remember if they taste more bitter or less bitter, the less potent they get, but they do have some sort of a flavoring mechanism there. But anyway, the point is, if your patient's opening it, make sure you're giving them a new one about 6 months after they've had it, and don't keep it in a hot area like hot cars, which is tricky because how exactly do you carry this around and not expose it to extreme temperatures is a tricky situation. But yeah, especially for a woman, you could keep it in your purse. For most guys, I don't know, I'm keeping it in your pocket. Talk to people who they'll take a couple loose tablets and keep them in their pocket so that they aren't exposing the whole bottle to the heat of their body throughout the day. So I don't know. There's a lot of things that probably aren't ideal, but however you can keep the drug with you in the best way possible is okay, probably. So for people who have chronic angina and are using nitrates, our goal is to make sure they aren't popping sublingual nitro every day or multiple times a day. So there's a couple drugs that are long-acting nitrates. One's called isosorbide, which we talked about when we talked about Bidil. So isosorbide / hydralazine is Bidil. And this is just isosorbide. So there's two forms, mono and dinitrate. I'm not concerned you know the difference between the two forms. You should know them for your practice purposes, and the big difference is that extended release is mononitrate. So if you're prescribing these and you're like, oh, I can't remember the difference, dinitrate is multiple times a day, and it's less well tolerated. Mononitrate's a more extended release, and the side effects are lower. It has a very limited effect on blood pressure, but overall it should decrease the amount that somebody's experiencing chest pain throughout the day. So if you remember Imdur or isosorbide mononitrate, again, I'm not going to test you on the differences of this. I just want you to know isosorbide. But for your practice and prescribing these medications, you should know that difference. Ranolazine is a newer therapy with no effects on blood pressure or heart rate. Its mechanism is a sodium, potassium, and calcium ion channel effect, which may prevent calcium ion overload and increase contractility and pain. We aren't really sure how Ranexa works. It's brand name only. It's got some side effects. It's considered a second-line therapy, not a super common medication. All right, that's it for ACS.